Hi, my name is Dr. Zev Wainberg. I'm a professor of medicine and co-director of the GI Oncology program at UCLA School of Medicine in Los Angeles, California. So Barrett's esophagus is a syndrome that's defined as having changes in the epithelial tissue in the esophagus. And this is primarily in the distal part of the esophagus, where you see an abnormal change from one type of mucosa to the other. This is defined as a metaplastic change, whereby you see changes in the squamous epithelium being converted to simple columnar epithelial tissue. And this is something that is considered to be pre-malignant. What we see with Barrett's is that a number of people who are identified as having Barrett's is because of changes in that epithelial tissue that have been a consequence usually of long-standing esophagitis. And esophagitis is inflammation of the esophagus in which chronic damage to the esophagus is being done, typically because of what's called gastroesophageal reflux disease. That then leads to esophageal inflammation, which over time can evolve into Barrett's esophagus. And what we see is that the majority of patients that are found to have Barrett's esophagus start as a precursor of esophagitis, and that's how this syndrome is discovered. Now, the way we would make this diagnosis is via biopsy and endoscopic surveillance, which are characterized into different groups of cells of Barrett's esophagus, either non-dysplastic, low-grade dysplastic, high-grade dysplastic, or if needed, cancer, of course. What we're trying to do with Barrett's esophagus, what the GI doctors are trying to do, is identify those groups that are high risk themselves of developing into cancer. And that involves identifying people who have either high-grade dysplasia, which itself carries a very, very high risk to cancer, or low-grade dysplasia, which carries a risk of evolving to either high-grade dysplasia or beyond. Now, when someone is entered and defined as having Barrett's esophagus, they are then put into one of these screening programs where we characterize it a little more carefully endoscopically. And if there is evidence of dysplasia, which is significant, and by that I mean high-grade dysplasia, patients are often referred either for surgery at that point, because the risks of cancer are so extraordinarily high, or for things like ablative techniques, which can destroy the epithelial tissue and normalize the dysplasia to some extent. Now, when people who have low-grade dysplasia, Barrett's and low-grade dysplasia, often they're just treated with proton pump inhibitors, which themselves will reduce the inflammatory tissue within the distal esophagus and essentially have an impact on decreasing the risk to either high-grade dysplasia or cancer. Over the last 10 or 15 years, there have been a number of very large randomized studies, both in the United States and in Britain, which have looked at the risk of dysplasia evolving to malignancy, which is actually quite low, and what interventions can be done to reduce that risk. And in several large studies, there have been the suggestion in randomized phase 3 studies that intervening with a proton pump inhibitor at the onset of evidence of Barrett's and dysplasia can ultimately reduce the risk of evolution of that dysplasia from to cancer, to neoplasia, what we call neoplasia. Now, there's about 5 to 15% of people who get evaluated for heartburn at any given time. Heartburn is often used medically. We use the term gastroesophageal reflux disease. About 5 to 10% of those people will have Barrett's esophagus at their first evaluation with an endoscopy. And it's those people who we're trying to intervene on and try to prevent further evolution into further dysplastic categories. So really, Barrett's esophagus is a pre-malignant condition, a very uncommon risk to cancer, but it still is common enough that we should screen for it with any patients with prolonged gastroesophageal reflux disease, not responding to PPI, or somebody who has persistent gastroesophageal reflux inflammation.